I'm going to switch gears here because this talk is a very brief, fast, but very clinical take on approaching pain with psychopharmacologic therapies. This probably deserves far more than 10 minutes and 10 slides, but maybe it'll prime you. And I hope actually have a question for the organizers. I don't know if these slides are made available to the conference. If not, I'm happy to share them because there's references that I'm going to ask if anyone wants to review to get into that. A little bit of background. I was working at the Cleveland Clinic as a general psychiatrist or a medical psychiatrist when I was lured to work in pain medicine, and I never regretted that decision. I learned quite a bit in the chronic pain department there and became medical director for a few years of the chronic pain rehabilitation program, where I learned most of what I'm going to be talking about today. And in that role, I saw patients one-on-one in clinic, but I also saw them as part of a multidisciplinary or interdisciplinary effort, a day program that incorporated PT, OT, psychology, and other services. So keep that in mind. The patients we were seeing had significant psychiatric comorbidities. I won't go into the epidemiology of psychiatric comorbidities in chronic pain. I hope that you're well aware of that, but it's high. And as such, I would say that if you are a clinician with prescribing capabilities, you should be thinking about these therapeutics, or at least be familiar with their use. So, I stole this from my mentor and the previous director of the chronic pain rehabilitation program. He was actually president of this organization many years ago. His name is Dr. Ed Covington. He shared this in his talks, and now I'm sort of passing the baton on or carrying it. And basically, he talked about all these various common therapeutics that had either analgesic, antidepressant, anxiolytic, or combined effects. And I think the temptation in chronic pain is that when you have somebody with chronic pain and depression or anxiety, that we just look at that one center area there where the three circles overlap, and that we basically liberally prescribe tricyclics and SNRIs. And there's nothing wrong with that per se, except in very complex situations where it oversimplifies the scenario. So I'm going to unpack the medications that do have at least two of these three functions. But keep in mind, this may be actually the most important guide as you go through your prescribing, if you do prescribe psychotropics in chronic pain. So a little bit on mechanism and why the SNRIs and TCAs in particular are relevant here. It turns out that our biological hardware depends on certain neurotransmitter action for analgesia, with serotonin and norepinephrine, 5-HT being serotonin and norepinephrine being very relevant in the use of these medications. It's been shown that the analgesia is actually blocked by co-administration of antagonists of these two neurotransmitters in central regions. And so this is the basis of why SNRIs and TCAs help, but other things like SSRIs, which are selectively serotonergic only, do not work for pain relief. So it's always important to know that. Sometimes this is, sort of taken for granted in medicine. I've found many patients who respond very well to this kind of psychoeducation, explaining to them that this isn't just us, trying to shrink your heads with these meds. This isn't just us trying to address stress and depression. There's actual neurobiology involved here. And there's a subset of patients who really, respond well to that kind of preface. So keep this in mind, of course, as a mechanistic background. I'm not going to get into any more hard science today. I want to keep it very clinical and have suggested directions for the use of these various medications. So the tricyclics have received a lot of attention. This is more review, but if you're not comfortable yet prescribing them, I invite you to. They do have side effects and they do have complexities to them. So there's trade-offs, obviously, to consider, but they have a strong body of evidence in a number of pain disorders, whether it be neuropathic pain disorders, headache, gastrointestinal disorders. I'll review those indications in a second. First, here you have them divided into their two groups, the tertiary and secondary amines. I don't know that you need to know too much about their chemical composure, but you do need to know that they do have different side effect profiles based on whether they're tertiary or secondary amines. The top bar or group includes the most famous one, amitriptyline or Elavil, that is liberally prescribed for a number of pain disorders. But as you can see, it has a lot of plus signs there in terms of side effects and metabolic and cardiac effects. So you're going to have to use that, in a clinical way with your patients, and you may get many discontinuations because of the side effects, something to consider. Whereas the secondary amines have less of these side effects. So you might pick these for folks who have exquisite sensitivity or have failed some of the ones in the top. Or for example, if you have advanced age geriatric populations who can't tolerate some of these other effects in the top. Suggested doses are on the right there, including initial dosing, max dosing. Don't quote me on this, but these are just rough parameters, and you're going to have to take each case by case, of course. And as I mentioned at the beginning of the 10 minutes, there's a lot of referencing here that I suggest you kind of review if you want to unpack it further. The other part of this is understanding what are the indications in which we can use TCAs. As the title of our review suggests, they're really designed for more than depression. There's headache, migraine, neuropathic pain, back pain, fibromyalgia, a host of conditions that have shown a signal of evidence, at least moderate, sometimes even higher than moderate, of efficacy. That being said, you do have to take each case into account individually. And I have some tidbits there for the clinician who may not have, say, a psychiatrist or someone else to prescribe these and is prescribing them themselves. You may want to mitigate for some of the side effects through these strategies over here. Things that are anticholinergic, antihistaminergic, metabolic. You can offset some of these if in fact one of these medications is really delivering a good quality of life for your patient, but there's pesky side effects. I would invite all of those kinds of strategies as they apply. Of course, I would be remiss if I didn't mention that TCAs can be dangerous in overdose. So the most important thing that you need to do is make sure that you do not have somebody with a very serious impulsive suicidal history. This is the reason why SSRIs are very popular in depression management, because in overdose, they're pretty safe. But tricyclics can kill, unfortunately. They can be lethal. So that's the number one thing to screen. The next most important thing to screen is probably any QT prolongation syndromes, just in case your patient has a rare disorder or other medications that prolong the QTC to the point of high risk. You don't want a cardiac event on your hands, of course. Before I move on, though, from the TCAs, it's really important that we take a nuanced look at them and not just think of them as somewhat toxic, somewhat complex meds. I've had many patients who have transitioned from SSRIs or other medications, or SNRIs too, which we'll talk about, to TCAs, and swear that they'll never go back because part of their pain has been relieved or their sleep or something else. So let's not, categorize them too simply as complicated. The SNRIs came around after the SSRIs historically with the promise of potentially addressing pain pathways, but without the toxicity and the lethality of TCAs. Unfortunately, their efficacy has not been as potent or as strong as that with TCAs. They do have a role, and I'm not going to spend, again, we only have 10 minutes, so I want to get to other classes of meds, but their role is limited and the efficacy has not been borne out as much as we all hoped. This is a statement from a Cochrane review that looked at basically duloxetine and milnacipran in fibromyalgia specifically. Of course, there are other studies in which the SNRIs have been used, but their outcomes were really not very robust. And so I would argue that if you have somebody with more than just moderate pain and significant psychiatric disability, that you think outside the box and not just prescribe Cymbalta, to everyone as we sometimes see. And I'm sure, there's differing opinions around that, but at least in the practice that I was involved in, the patients that I get referred now, I rarely see that they're doing just fine with Cymbalta or duloxetine. I want to quickly address another class of medications that belongs to psychiatry, although it also belongs in neurology, and that's the anti-epileptic agents, which we call mood stabilizers. So obviously they suppress epilepsy and they do other things, but we use them to stabilize mania and to regulate mood and to do other things in psychiatry. I probably won't spend too much time on gabapentinoids because that's something that is very well ingrained in pain practices. And I suspect if you're a prescriber in pain medicine, these agents, but there are a number of conditions in which they're used. And obviously there are side effects that need to be monitored, including sedation, dependence, withdrawal, abuse, and of course, renal clearance. So I don't want to unpack those too much. A couple of other ones that are less sought are carbamazepine and oxcarbamazepine. They actually have a robust body of evidence in different episodic pain disorders, paroxysmal pain disorders, neuropathies, neuralgias, et cetera. And so I suggest, turning to those before abandoning hope. But of course, being mindful of the various drug-drug interactions, CYP 450 interactions, and other side effects. A few others that I think sometimes are forgotten, although it depends what practice you're in. Topiramate or Topamax is well known to be effective in headache and migraine prophylaxis. So neurologists who do pain management or others who manage headache are familiar with it, but I think sometimes other pain interventionists, for example, who have to prescribe, forget about its role. And it's pretty well tolerated, although at higher doses, you can see cognitive side effects and renal calculi and other issues. So you'll have to be nuanced about that. Lamotrigine also is interesting. It's a great mood stabilizer in the world of psychiatry, but it also has some evidence of effect in certain neuropathies. So it's probably not first line, your first choice, but if others have failed, you may get some results in some stubborn pain disorders like post-stroke central pain, for example, with lamotrigine. You'll have to be careful, of course. The well-known side effect that is dangerous is Stevens-Johnson's rash. So you have to go low, start low and go slow. Valproic acid is one of my favorites that I use quite a bit in both psychiatry, but also in stubborn pain disorders, using a dose range that is quite broad. For different neuropathic pains, but even headache and other pain disorders. It's a very potent anti-epileptic and mood stabilizer. You're going to have to watch for liver disease and thrombocytopenia in particular, but also sedation. And interestingly, here we have lithium also has a bit of a body of evidence for cluster headaches, believe it or not. It is a mood stabilizer, not an epileptic, but it's very helpful in folks who have severe mood disorders, chronic depression with SI is suicidal ideation, part of my jargon. And it can be a very good adjunct for some patients, but you're going to have to be careful, of course, with monitoring its levels because it can be toxic. So this is the two slides here for mood stabilizers slash anti-epileptics is really just meant to be a reminder. Dip into the grab bag because there's a little more out there than, say, opioids or other things that obviously have significant problems with them. The last class that I'm going to review very quickly and then pause for any questions is the antipsychotics or neuroleptics. There's always been controversy as to whether they have a role in pain management. It looks like there might be a role in certain patients and with certain doses as adjuncts. So a lot more nuance here needed. We did a recent review, myself and Dr. Covington I had mentioned earlier, looking at the literature in terms of trials, case series, case reports, retrospectives, using atypical antipsychotics. These are second generation or newer antipsychotics. And we found that essentially olanzapine, which is also known as Zyprexa, may have a bit of a signal there in very specified roles, particularly those in which there's high central sensitization burden and psychiatric comorbidity. That shouldn't be surprising. If you know anything about olanzapine, it's actually quite anxiolytic. It's actually quite effective at stabilizing mood. And so maybe in an indirect fashion, it's helping that way rather than helping with analgesia. But if you are busy enough in a pain practice, you will run into patients with complex PTSD, maybe even some severe psychiatric disorders. They may not even be following with psychiatry out of stigma and other reasons. So it's an opportunity for you, if you become comfortable using these as adjuncts, to maybe make an impact. Quetiapine is another one that has a little bit of a signal. If you want to look at the evidence, I refer you to the article. And then this chart that I have here is basically a sort of dummy-proof way to make sure that you're prescribing these medications responsibly, to watch out for things like metabolic syndrome or QTC prolongation or any of those things, with time points as to what to do. And that's embedded in that article. To conclude, this is the busiest slide, but again, you can review the references. To conclude, when you're doing your chronic pain assessment, and each of us does it differently, but hopefully there's some multidimensionality to it. As we parse apart nociceptive versus neuropathic, central sensitization syndromes, et cetera, it's probably important to really incorporate a biopsychosocial approach and look at, first of all, what are your obstacles, such as high dose opioids, of course, benzos, are they getting in the way? Second of all, is there an opportunity with the really robustly determined ones or demonstrated medications, like gabapentinoids and TCAs, SNRIs, Obviously complement that with physical therapy, OT as indicated. Over on the right, if there's significant psychiatric burden or central sensitization or both, psychological therapies need to be incorporated pretty early on. But if you have really psychiatric with a capital P comorbidity, I would invite, this may sound controversial, but I would invite pain providers to dabble a bit with light, low dose and well-monitored antipsychotic usage for the reasons that I mentioned earlier. I don't know that every patient's really going to be thrilled to go see psychiatry, so you have an opportunity to make an impact in your clinic, even if you later consult with a psychiatric colleague just to, protect yourself. And then finally, just to conclude, the cartoon at the end, the Venn diagram, is a reminder to think in nuanced ways of how you would incorporate those medications into this kind of rough algorithm, which is again embedded in that reference down there. So it's a lot, it's 10 minutes only, and I apologize if it was a little fast, but I'm happy to take any questions, and thank you for the opportunity. Yeah.